Well, good morning to everybody that's on the phone call. Dr. Brodie and myself are actually both in the same room here in Fort Myers, sunny Fort Myers, Florida, I should say. Sometimes for these webinars, we'll be located in different locations and just communicating via the internet, but we're actually both here in Fort Myers at NeoGenomics main laboratory location. So welcome to everybody. I want to make sure I have control of the screen. Oh, I do. Okay, good. So my first slide that you should see on your screen is just an introduction and overview of the high-level overview of the agenda that we're going to talk about today. And actually, it's broken up into about 4 segments. The first 2 segments I'll be covering, and the second 2 segments Dr. Brodie will be covering. I'm going to start out talking a little bit about the challenges inherent in conducting oncology clinical trials, just some high-level overview around oncology clinical trials, and then more specifics around some of the high degree of variability that we see in the anatomic pathology testing that's related and included in almost all of these oncology clinical trials. Dr. Brodie will then talk about some of the added complexity that we have just with oncology as a disease state in terms of some of the genomic variability that we see within these classes of tumors, and talk a little bit about some of the flexibility that's needed in clinical trial design in order to account for that variability. And then lastly, Dr. Brodie will talk about some of the flexible algorithms and testing methodologies that were required in this area. That's the next slide. So at a high level, many of you on the call are probably aware that oncology is a huge segment in clinical trials, and this data actually shows the number of clinical trials, 2013 actual, 2014 estimates for various therapeutic areas. And as you can see by looking at the graph, in the center of the graph is cardiovascular. Oncology to the far left, or anti-cancer to the far left, really dwarfs that clinical indication, which is a fairly large clinical indication, and even neurology and anti-infectives, which are huge areas of exploratory research, it dwarfs those as well. It's expected that the number of oncology trials will go up by about 5% between last year and this year. So not only is it the largest number of clinical trials, it's also an area of continued growth. And almost every major pharmaceutical company is in the oncology space in one way, shape, or form. However, as many of you may know, oncology clinical trials actually suffer from the worst approval rating for any of the clinical therapeutic areas. So in this case, on the far right of the slide, we see how oncology does in terms of approval for a drug that makes it to phase 1, making all the way through to approval. And it's less than 7% of all oncology trials end up with a drug that's finally approved. Again, if you look at some of the comparators there on the left, infectious disease, autoimmune, more than double the rate of approval for a drug that makes it to phase 1 that finally gets approved. So quite a bit of difference there. It's a large number of trials, but not the most successful area in terms of throughput in these indications. At Covance, we have a significant amount of experience in dealing with complex oncology trials. We have laboratories in all the areas that are located, shown on the map, and we have basic histology capabilities in all 5 of those locations. Over the last 5 years, we've run over 1,000 protocols for oncology indications involving nearly 80 countries and close to 150,000 different patients. And the bang box on the right is interesting in that at some point in the development process, Covance has participated and helped develop 47 out of 50 of the best-selling oncology drugs. So we have quite a bit of experience in running these trials. And from that experience, really, we've seen a lot of issues with the areas in anatomic pathology, and that's part of what we'll talk about today. So what I'm going to do in the next few slides here is look at the complex testing, the tissue-based markers, which we do in pathology for oncology trials, through the lens of breast cancer and estrogen receptor, progesterone receptor analysis, and some of the findings that have been written up regarding those types of immunohistochemical analyses. Dr. Brodie is going to talk a little bit later on about HER2, so I won't really touch specifically on HER2. And what I say for ER and PR really can be applied to all tissue-based immunohistochemical markers, but there's just a lot more written around the areas of ER, PR, so we'll use that as an example. And when we look at testing within the laboratory, we tend to divide it into pre-analytical and analytical. So pre-analytical, anything that happens before the actual testing process. Analytical is kind of self-explanatory. That's during the testing process. But we further subdivide within anatomic pathology, different than a blood tube-based test, a technical and professional component. And that really comes from actually the U.S. Medicare system, where the billing works that way. There's a technical and professional billing component. But the technical component is really any of the basic steps in the testing process. So bringing that sample, that biopsy in, taking it out of formalin, putting it in a paraffin block, cutting the slides, staining the slides, all those are part of the technical component. The professional component is the pathologist then looking at that stained slide under the microscope. Both of these areas are subject to variation or variability. And if we look at pre-analytical first, we see that there's differences, and this has been written up a lot for ER and PR, in pre-fixation cold ischemia times actually make a big difference in the end result and what shows up as positive for estrogen or progesterone receptor. So what does that mean? What is cold ischemia time? Basically, ischemia time is divided into warm and cold ischemia. Warm ischemia time defines the period of time from when the surgeon actually ties off the blood vessels to the tumor to the point in time when that sample is removed from the surgical field and placed with the circulating nurse. And the cold ischemia time is from the time that sample comes off the table until it's actually placed in formalin. So it's off the table, but it's not in formalin. That's cold ischemia time. So looking at cold ischemia times, we know that there's a huge difference in the ability to stain positively for ER or PR based on the length of time that sample spent cold and not in formalin.